vessels. The spinal cord also has pressure on the blood vessels. It will lead to lack of blood supply to the spinal cord. That can lead to degeneration of the spine. When you read an MRI, sometimes you will find a report saying that the white matter of the spinal cord is actually getting deranged. That is because of compression caused by and which is causing a blood supply problem to the spine. So all these different conditions can actually cause pain. So among all the different causes, the most common cause is paravertebral muscular spasm. It's the most common cause. But it is not associated with structural damage. It's a temporary phenomenon. If you sleep with your neck in a very odd position, you can get a pain. You lift something, you are sitting in a not so comfortable chair for a long time, you get a back pain. That is all paravertebral muscular spasm. The muscle is tight. In a couple of days, it will go away. So that is not having any structural damage there. Whereas the most common problem that is caused by structural damage is due to the intervertebral discs. That is the most fundamental structural cause of pain and other symptoms. Now we will see about the intervertebral discs. So as you it's a disc, okay, that's not really visible here. As you go below, the space is larger. The larger the space, the larger the disc. Given the size of the vertebra, you will observe that the cervical is thin. As you go to the thoracic, the size becomes bigger. When you go to the lumbar, it becomes even bigger. And finally, the sacral bones are all fused together. It is like one bone. So you can see the size of the vertebra as well as the size of the disc increasing as you go below. So the discs together account for 20 to 30% of the length of the spine. So disc is a very important structural thing. You will find many people will lose height as they become old. Their height actually will come down because the disc which was so thick, with aging it starts becoming compressed and it becomes smaller. So you will lose height as you become older. Increase in the scale, and you can see the increase in the size of the disc from the cervical to the lumbar. They are bounded by longitudinal ligaments. See, the cervical disc is also kept in place, or the entire disc, the intervertebral discs are kept in place by ligaments. So a ligament is preventing this disc from moving away. So this disc is actually sandwiched between the two vertebrae, and just before the spinal canal, there is a protection in the form of the posterior longitudinal ligament. The intervertebral disc in place, and they are also bounded by the end plates. I told you it is stuck to the vertebral bone through the end plate, and anteriorly there is also a longitudinal ligament. Posteriorly there is a longitudinal ligament. So you can see this picture here. That is the superior articular surface. Here you see the intervertebral disc. I'm not sure the color is very clear. The blue color is the intervertebral disc, and then you have the next vertebra and so on. Each disc is made up of two parts. The hard, tough outer layer called the annulus fibrosus, and the sort of gel-like interior soft tissue which is called as the nucleus pulposus. We will look at more detail. This is a side view of a disc. So you can see that this is a vertebra, this is a vertebra. In between them you have the intervertebral disc. Look at the vertebra from above. This is how the disc appears. You can see the internal portion is looking slightly different from the external portion. So this is like a disc shape. That is why it is called as an intervertebral disc. And as I told you, along this structure, this is how the posterior longitudinal ligament is holding it, and it is stuck onto the vertebra. So this inner portion is like a jelly. This is called as the nucleus pulposus, and it is surrounded by a fibrous structure that is called as the annulus fibrosus. The vertebral body is connected and kept separated from by intervertebral discs. The disc is comprised of the annulus fibrosus and nucleus pulposus. They are firmly joined to the end plate, and the end plates are composed of hyaline cartilage. So I told you, from the bone it becomes cartilage, and then there is the disc. The end plates undergo progressive calcification with age, which impedes the nutrient source. So that is what is happening to the disc. It's very important to know that the disc does not have blood supply. You know how the tissues of the body are nourished is through blood supply, is it not? The nutrients come to the tissue through blood supply, whereas the intervertebral disc does not have blood supply. Because it does not get blood supply, it gets its nutrition through the surrounding tissue as well as primarily from the bone. As you become old, the end plate or the cartilage becomes calcified. Calcified because there is a lot of calcium deposition, which makes it almost like a bone. That makes it difficult for the nutrients to transfuse into the intervertebral disc, and that causes lack of nutrition to the disc, which itself is a pathological process. So that contributes to progressive degeneration of the disc throughout adulthood. It's very important to know. The nucleus pulposus is located posterior-centrally in the disc, where in the lumbar region it fills 30 to 50% of cross-sectional area. So in the lower disc, a large area is covered by the nucleus pulposus. And the normal nucleus consists almost exclusively of type 2 collagen fiber in an aqueous gel rich with proteoglycans. What is a proteoglycan? It's a combination of carbohydrates with proteins. So amino acids plus carbohydrate, that combination is called as a glycoprotein or a proteoglycan. Water content in the normal nucleus of the human lumbar disc decreases from about 90% during the first year of life. So in a child, the nucleus pulposus is so full of water. There is 90% water in the intervertebral disc. But with growing age, it keeps on reducing and finally it goes down up to 74%. I mean, it can go even, this is normal, I'm saying. Pathologically, this becomes much lesser, much earlier, and that is the first of a disc. That is called as dehydration of the disc. So water in the disc is a very important element because this needs to be like a sponge. It has got to be soft. It must absorb the shock that is happening. I told you a lot of load is coming onto the vertebra. So when the discs get compressed, that force has to be dissipated. That is done by the nucleus pulposus. That's why it needs a lot of water. So this is how you can imagine. I always talk about a stuffed paratha. You must imagine the disc like a stuffed paratha. Inside there is a soft filling, outside there is multiple layers. Layers which are going circular, layers that are going one on top of the other. So these are like circular layers. These are called the annular layers. So this is fibrous. So it is like mesh. One layer is arranged this way, one layer is arranged this way. At 120 degrees they are arranged between each other. So that it forms like a strong mesh, preventing this nucleus from going out. So when you are pressing the disc by jumping, or when you are sitting in a vehicle and the vehicle is just jumping like this, you are putting tremendous pressure on the disc. That pressure tends to push the nucleus pulposus outward, and the annulus fibrosus is trying to hold it together. This is how this whole disc is working as a shock absorber. So such a beautiful design. But when you don't drink water enough, when you are not exercising, when you don't exercise, the blood flow to that area itself is low. When you are not exercising, the disc becomes hard. The water content goes down. Imagine you have got a shock absorber without the spring. So your disc becomes like a hard substance, and then it cannot give you that cushioning effect. So whenever there is a jump, it tends to burst. You can imagine a soft thing when you press, and then again regain the shape. When the softness is gone and the disc becomes hard, which happens with dehydration. First of all, the height will come down. It will automatically become thin because there is a constant pressure which will make it already bulged and sharp. Severe pressure will tend to push the nucleus pulposus outside and the annulus breaks, allowing the nucleus pulposus to come out, and that is actually disc prolapse. Very often, whenever we imagine disc prolapse, we think the disc is moved out of place. Then it prolapse immediately, like the rectal prolapse, we think the rectum has come out of position. Similarly, we may think the disc is going out of position. It is not going anywhere. If you go like that, you will die. So disc doesn't move just like that. The disc is actually. So this structure is very important for you to understand. So these are some beautiful images of how the disc is. If you look at a typical, this is like a cadaver cross section. This has got the annulus pulposus, and this area is the annulus fibrosus. This is the nucleus pulposus, and this is the annulus fibrosus. You see all around there is this annulus fibrosus. So what are the stages of degeneration? So this this disc is one of the culprits we said. Other than muscular spasm, the most common structural problem that affects the spinal cord is disc degeneration. And what happens in a disc degeneration? The first thing that happens is dehydration of the disc. So the starting point is water getting lost. What is the property of water according to Ayurveda? Snigdha. So we say snigdha is getting reduced. As we become older, vata increases, so snigdha goes down. What is actually that is correlating exactly with the modern understanding. The dehydration is the foundational step in this degeneration. So snigdha is already getting reduced. Once this reaches the dehydrated state, then still there is a pressure, it is subject to tear. So the annulus fibrosus, when the pressure increases, starts cracking. And that is the second stage, which is called the tear in the annulus fibrosus. Next is protrusion of the disc. The disc can actually protrude out when the annulus is cracked, and we are applying pressure. This internal pulp will just come out, like we are pressing a seal. This will just come out. Then after that, when this keeps happening for a long time, you start having inflammation, and therefore, as a healing mechanism, the body starts growing bone. That is osteophyte formation. Lastly, what happens is the bone grows into the cartilage and the cartilage grows into the bone. That condition is called as osteochondrosis. The bone gets invaded by the cartilage. So both the bone and the disc lose their shape. That is the most advanced stage of disc degeneration, and that is called as osteochondrosis. This is a schematic representation of what is happening in the disc. So this is a normal disc. Here you can see a degenerated disc. See, the height is reduced. This is called a degenerated disc. This is a bulging disc. Actually, this looks a little bit like a prolapse, but it is not generally like this. What will happen is this will be like this, and here also it will be moved slightly. That is called as a bulged disc. Here you see the annulus is broken and the disc is prolapsed. This is called a herniated disc or a prolapsed disc. This is a thinning of the disc, and here are the higher levels of degeneration. As I told you, the shape of the bone is gone. It starts developing osteophytes. These are bony protrusions into the spinal canal. And see the shape of the bone itself becomes like this. Instead of the structure, there will be a small convexity. Here it becomes like a small jutting out portion is there when the disc is highly degenerated. If you take the X-ray of an old person, invariably you will see the vertebral body like this. But doesn't mean they must have pain. That is a very important thing to know. Just by looking at the X-ray or an MRI, don't diagnose somebody. Anybody above the 50 will have degeneration in the disc. Nowadays, I think even earlier, by 40s itself, people are becoming old. I'll show you some radiographs to help you identify. If you see this is the MRI for a 13-year-old child. Look at it. Excellent. Main thing you have to note, if you are looking for the disc is whether these two colors are distinct. You will see a different color in the center based on the T1 or T2 image. This will be dark too, this has to be light, and vice versa. In the T2 image, you will find this to be light and the other one to be dark. This differentiation between nucleus fibrosis and annulus fibrosis is very important to note. Suppose this is not there, suppose the whole area is dark or the whole area is gone, that is called a degenerated disc, that is a dehydrated disc. No structural problem, there is no bulging, but the color has become black. Then you must understand that it is a dehydrated disc. Here this disc is normal, but here you can see this is a fully dehydrated disc. Here there are other things, there are some cracks. This is a typical prolapsed disc. The nucleus pulposus is bulged out. Here is a torn disc. You can see an axial tear. I hope you are able to see that image. So that is an axial tear that has happened in the disc. This is also another image where you can see a dehydrated disc which is also prolapsed. Not too much, because if you look at this line, it has not been interrupted. That means it is not prolapsed too much. Here also you have got a completely dehydrated and degenerated disc with a slight prolapse. You can have extremely high levels of prolapse also in some images. So this is again the nucleus is desiccated. The posterior disc margin, there are two types of tears here. One is just along the surface like this, there is a tear, but that does not cause a problem. Because if there is a tear like this, the nucleus is sitting there, it cannot these type of tears happen initially, and that weakens the annulus fibrosus. That is when the whole thing ruptures. Just to show you that here this is a full rupture. Here it's a full rupture. It's called an annulus tear. So it's like the fibers are like this, it cracks open and the nucleus pulposus is just jutting out. This is a cross section of the spine for you to appreciate. This is a typical disc prolapse. No problem. I think till then we can use the time to ask any doubts that you have up to now. In two scenarios, there will be no doubts. Either you have understood everything or you have not understood anything. I hope it's not the latter. All clear? Very good. Thank you. I'll have some water. You can finish with the certificate process, then we'll start. All done? Good, thank you. So here, as you can see, this is the intervertebral disc, and you see here, this is a herniated disc or a disc prolapse. So you see the spinal cord here, and this is the spinal nerve that is coming out. So here, when the disc has prolapsed, see it is going and pressing on the spinal nerve root. So this is called a lateral prolapse. So you can have a prolapse of the disc here also. This is called as a central, posterior-central bulge. This is a lateral bulge. If it happens on the sides, it's a lateral bulge. And a lateral bulge is likely to cause compression on the emerging nerve root. That is what has happened here. If there's a central bulge which happens here, it will go and press on the spinal cord. Actually, there is more gap here. Some level of bulge that is happening in the central portion, the spinal cord is not touched. There is no space here. No. But unfortunately, in very few people, congenitally, there is a very narrow spinal canal. For some people, that condition is called as spinal stenosis. So people who have a very narrow spinal canal, even a small prolapse can go and press on the spinal cord, and that can cause problems. What is the type of pain problem that happens when it presses on the spinal cord? What type of pain? Funicular pain. Funicular pain happens when there is a pressure on the spinal cord. When it presses the emerging nerve root, what pain happens? Radicular pain. Yes. So this is what causes cervical or lumbar radiculopathy. So when a disc or some structure, it can be an inflammation of this articular process also, which is pressing on this nerve. It can cause radiculopathy. Anything pressing on this spinal emerging nerve root causes radiculopathy. Anything that is pressing on the spinal cord causes myelopathy. That is the condition's name is called myelopathy, which means it is pressing on the myelin sheets which are there in the spinal cord, and that causes problems. According to the area of the which type of tract is getting compressed, accordingly the symptoms will vary. Did you understand this now clearly? So this is the superior articular process. So when the superior articular process also has got a cartilage there. Suppose there is an arthritis in this joint, this can also go and press on this, and that can cause radiculopathy. Radiculopathy and myelopathy. Now we are looking at the advanced stages of disc degeneration. Where I said, the difference between the bone and the disc itself is lost. Now you see that the bone is migrating into the disc. Here also you can see the disc is growing into the bone. These conditions are called as, this is sclerosis of the vertebral end plates. The vertebral end plate has completely become sclerosed here. But this area is all not strong. This type of bone can easily get affected by compression fracture. That is advanced stages of degeneration in the disc that is happening. The gap is also completely gone. The bone is almost touching each other. The disc is only a small portion here, and all these areas of the bone are not getting enough blood supply, and they become sclerosed. Now, why are these changes happening? What is causing the damage to the intervertebral disc? All these damage that you saw. The first thing that we know is age-related change. Age itself causes the dehydration, as we saw from a young, just born child. As they become older, the hydration level in the body goes down. Premature degenerative changes. So that is a natural aging that is happening. See, traditionally, these problems are supposed to come after the 60s. Now people are getting this in their 20s and 30s because that is premature degeneration. Why does that happen? Two types of causes. One is mild repeated trauma. We all know about somebody who gets to a bike accident or a car accident, suddenly has a fall and the disc is ruptured and the bone is ruptured. That we all know. But even without that, even traveling on a bad road or two-wheeler and all that, where you are jumping up and down, it is a continuous mild trauma. It's not a severe thing. It's not that you had a severe fall or a sprain or anything. It's a small trauma that is happening continuously. That also leads to degeneration of the disc because you are continuously applying the pressure. That is why when people have this problem, they are advised to wear a cervical collar or a lumbar protection belt when they are traveling. That is the reason, because the mild repeated trauma also. Once you have got a big jerk, yes, it is likely to happen. Even without that, it can happen. The small jerk that is continuously happening also makes premature degeneration possible. Pathophysiologically, what is happening? Really, what is happening inside? The two major things that are happening is one, the H2O content or the water content is coming down both in the nucleus pulposus and in the annulus fibrosus. So the water content reducing is happening in both the areas. Number two, the proteoglycans, as I told you, that is the amino acid plus protein combination. The proteoglycan level is also getting reduced. Disproportionate loss of contractile sulfate with as keratin. So these are the two substances that are present within the disc. The ratio of which determines contractile sulfate, it makes it a little bit more capable of holding water, and keratin is something more hard, like what we have in the hair. So keratin increase along with chondroitin sulfate decrease reduces the elasticity of the disc and loss of imbibing capacity of the disc. Even the disc's ability to capture and hold water is gone. So you must have experienced a rubber, a soft rubber. If you put it in the sun for some time, what happens? It will become hard because the water content is lost. After some time, you try bending it, it will break. Same thing is happening to the disc. So I hope you understand what is happening to the disc in general, the spinal canal, and what is happening to the spinal canal. Now we will go into specific diseases. First, we will deal with the cervical degenerative disease, which is called as cervical spondylosis. Cervical spondylosis is a term applied to chronic degenerative disease of the intervertebral discs of the cervical vertebra, associated with reactive changes in the adjacent vertebral bodies. So first thing that is happening is the disc is getting degenerated, and once the disc is degenerated, even the surrounding tissues like the bone can get affected. That condition is called as cervical spondylosis. So all neck pain is not cervical spondylosis. Incidence and prevalence. The vertebral column, its contents and surrounding structures are responsible for some of the most common problems of people. Neck and or back pain originating from these structures affects almost every individual at some time in their life. Almost everybody would have had neck pain or back pain sometime in their life. Every year, 4% of people suffer an episode. And the disorder ranks next to alcoholism as the leading cause of time lost from work. Why people are taking leave? One of the most common causes worldwide is supposed to be neck or back related problems. Alcoholism is supposed to be thing. I don't think still it is that stage in India. But in most other countries, alcoholism is the leading cause of time lost from work. The next highest one is spine-related problems. Now I told you about cervical radiculopathy and myelopathy. Especially, this is very common to see. Myelopathy and radiculopathy are two distinct spinal issues that can exhibit similar symptoms. Myelopathy refers to a condition known as spinal cord compression, while radiculopathy occurs when a nerve root but not the cord itself becomes compressed. The latter is more commonly known as a pinched nerve. So you can see here, this is the sheath through which the spinal nerve is emerging. When here it is pressed, it produces radiculopathy. When here it is pressed, it produces myelopathy. Now you are very clear, even in your sleep you should remember this. Cervical radiculopathy. What does it cause? When radiculopathy happens in the cervical region, it is called as cervical radiculopathy. You know there are different cervical vertebrae, isn't it? So accordingly, symptoms are different. Based on which area the radiculopathy is happening, accordingly the area where you will have the problem is different. But the general symptoms are pain or tenderness in the neck. First you will get pain or tenderness here. Not that all of them should be there, some of them will be there. Pain or numbness in the shoulders, hands or fingers, weakness of the muscles of the hands or fingers, difficulty and restriction in neck movement, occipital headache. You can also have headache here in the occipital region. The upper cervical vertebrae, when they are compressed, it produces occipital headache. Dizziness aggravated by jerky neck movement. So when people are moving, they can get giddiness. One of the causes can be vertigo. It can also be caused by cervical spondylosis. These are all some of the very common symptoms of cervical radiculopathy. Cervical myelopathy. It can also cause pain in the neck or back. There can be tingling or numbing sensation in the arms, legs or feet. Very important. Cervical myelopathy will produce weakness or tingling sensation in the legs. Why? Because the spinal cord is carrying the nerves that are coming to the lower part of the body. And when the spinal cord is compressed, it produces tingling or numbing sensation in the lower part of the body. Difficulty with fine motor skills. They will have problem holding a small object or in small movement. Like moving the hand they can do, but small movements are difficult. That's a sign of myelopathy. Like buttoning a shirt. I mean, this is not the only cause of that. There are other neurological diseases which can cause that. So for each of this, there is differential diagnosis. But at least understand that cervical myelopathy can cause this problem. The balance or coordination issue that can also happen with myelopathy because the sensory nerves which are coming from different parts of the body are carried to the brain, and that is how we are understanding our sense of posture. That is how we are able to get our balance. So when there is cervical myelopathy, those nervous transmissions are affected, and that will upset your balance and coordination system. That is because you know how are we able to stand erect? Based on the position of the sense taken from the feet, position taken from different parts of the body, position from the ear, eye. From all this, there is an input going to the brain. All these senses are coordinated together, and the body understands in what position you are now and whether your balance is likely to trip. Based on that, it gives command to certain muscles to contract, to certain muscles to relax. So the pure, beautiful, and fast coordination of the upward and downward nervous impulses is what is enabling us to stand erect and have a sense of balance. Children don't have that because their nervous system is not fully developed. Old people again have a problem because the conduction is slow. When you are developing any disease which is making the conduction of the nervous system slow, you can have a problem with balance. That is happening because the speed at which the information is going there and the reverse information is not coming quickly enough. That causes imbalance. That is one of the causes of imbalance. Changes to reflexes in your extremities. So when you measure a knee reflex, DTR, I'm sure you have learned that. No? I mean, are you already done that? Some of you are not. Okay, so you will have deep tendon reflexes. So you can look for your knee reflex, knee jerk, or ankle jerk, or stuff like that. So when those reflexes, what will happen? When cervical myelopathy happens in the lower extremities, when you look for a jerk, the jerk will get exaggerated. You know, I mean, you have not learned the deep tendon reflexes skill. So those of you who are there, in the normal human being, if you are fully relaxed and you tap on this tendon, the patellar tendon, you will have a small reflex there. Whereas in the case of an upper motor neuron lesion, the nervous system is got upper motor neurons and lower motor neurons. First, the brain, within the brain is a motor neuron, that is the first cell. Then within the spinal cord is the second cell. And outside of that, in the spinal nerve is the third cell that is communicating to the muscle. So in the case the upper nerves are affected, you will have an exaggeration of the reflex. When the last nerve, which is the nerve coming from the spinal cord to the leg or to the hand is affected, you will have reduced reflex. So very, very important neurological examination to understand what is causing the problem. Person may have difficulty moving the leg. So you need to understand which nerve is affected. That is called neurological examination. So you do something called as deep tendon reflexes. When you do a deep tendon reflex in the lower limb and you find that the reflex is exaggerated, that means the motor neurons, the brain or in the upper spinal cord are affected. It's called upper motor neuron lesion. That will happen with cervical myelopathy. Whereas if it is the spinal canal which is compressed, you will have suppression of the reflex. Very important. When you go to neurology, in case you are having somebody asking you for an exam, this is one of the common things that will happen. They will ask you to examine a patient and say, what is the problem in this patient? Without any MRI, you should be able to identify whether it is the brain or spinal cord or is it the external nerves. Okay. It can also, cervical myelopathy can also lead to loss of bladder or bowel control. Because again, the spinal tracts are carrying the impulses to the vital organ, having to the bladder and bowels as well. So, cervical myelopathy can cause bladder and bowel control problem. In fact, we have had clinical cases. I have encountered a patient who had a problem with his foot. His foot was not working. They went to a hospital, they did an MRI of the lumbar spine, they found lumbar spondylosis, they did a surgery of the lumbar spine. Patient still the foot was not moving. They said, wait. You can take some more time, keep doing physiotherapy. After doing physiotherapy for a long time, that patient came to our clinic. I did a reflex tap, he was highly exaggerated. I said, your problem is not with the lumbar spine. He had cervical myelopathy. We treated him for cervical myelopathy and he started walking. So he underwent the surgery unnecessarily because the doctor did not bother to unless you have a full MRI, you will make a fool of yourself if you don't do full neurological examination if you are encountering a neurological problem. So, clinical presentation of nerve root lesions. So C2, C3, C5, C6, C7, C8. What is the C8? Cervical, how many vertebrae are there? 7 only. But the cervical region alone, the nerve emerging after the cervical 7 is called the C8 nerve. So C8 also is there. So pain occurs in a specific area, sensory loss in a specific area, reflex loss, specific reflexes are affected. For C2, C3 there is no reflex. Only you will have occipital pain. Whereas from C5 onwards, the biceps reflex is affected, supinator reflex is affected, triceps reflex is affected, and finger stretch reflex is affected. So without an MRI, you should typically able to isolate a cervical radiculopathy related disease. These are all cervical radiculopathy, not myelopathy. Because this is nerve root lesion. So sensory loss also, that is called a dermatome. Areas of the skin which are supplied by each nerve. So where is the numbness will also give you a clue about where is this problem. That is called dermatome. And then what all does it? You will have problem moving those muscles. People with severe cervical radiculopathy can have muscle loss. You can also see weakness in the muscle. I'm not going through all of this in detail. You can look it up. Just get the concept very clearly. You can do for all this information is there on the internet. But just get the hang of this one. So cervical radiculopathy and myelopathy can mimic. You can get confused with the diagnosis of so many different diseases. Adhesive capsulitis. Suppose there is just pain in the shoulder and in the hand. You can think it is cervical spondylosis. It can be another condition called adhesive capsulitis. There is another disease called Brown and Sequard syndrome. Carpal tunnel syndrome. Carpal tunnel is the tunnel that is here. So if this coming to the hand are going in. If there is a bony protrusion or there is inflammation here, this nerves can get affected and you can have numbness in the hands. That is called carpal tunnel syndrome. So you will get confused whether it is a carpal tunnel syndrome or is it cervical radiculopathy related numbness in the hands. So for all these investigations are got to be done. Most importantly, remember that these are all possibilities. Cervical myofascial pain. There are some people who just have tightness of the muscles and the fascia. It is just the muscles are tight. They will keep getting pain in different parts, one after the other. That's called cervical myofascial pain. Very often, cervical myofascial pain is associated with stress, anxiety, and depression. You have it's a sort of a psychosomatic disorder. Then the other one is called diabetic neuropathy. Of course, you've all heard about this. Long-term diabetes affects the nerves, and the nerves can create numbness, pain, lack of strength, and all that. That is called as diabetic neuropathy. Then you can have multiple sclerosis. It's a disease where it's an autoimmune disease where our immune system attacks the nerves and damages the myelin sheath, changing the multiple sclerosis. Brachial plexopathy. This is the brachial plexus that is coming here, the nerves, the group of nerves, and that is damaged either due to an accident or something. That can cause also similarly weakness, numbness, etc. in the hands. You must be able to distinguish between brachial plexopathy and cervical spondylosis. Rheumatoid arthritis. Sometimes rheumatoid arthritis affecting the spine can cause symptoms like cervical radiculopathy. Because I told you the superior and inferior articular joints, they are inflamed, they press on the spinal nerve roots, and that can cause radical. Osteoporosis, especially in the lumbar region, osteoporosis can easily cause pain, which is similar to radiculopathy. Spinal cord injury can also be having the same issues. Tuberculosis of the spine. Tuberculosis of the spine can cause compression, either it can cause myelopathy or radiculopathy. So that needs to be evaluated. Tumor in the spine is another possibility. Thoracic outlet syndrome. So all the regions that are coming here through the thoracic area into the arm access or to the blood supply, that can cause symptoms very similar to cervical radiculopathy. Syringomyelia is another condition. Syringomyelia is a condition where in the spinal cord there are fluid-filled cavities which are developing. It can either be congenital or it can happen afterwards due to an infection which resolves. And then inside the spinal cord there is fluid accumulation. That condition is called as syringomyelia. All this can be found out through MRI. Chronic pain syndrome. There are some people who have pain all the time. Different parts of the body will keep paining. I will talk about it a little later. Very important to understand this. They will say today the pain is better here, now it is paining here. Then it is paining here. Then it is paining here. Pain will keep shifting, but there is always pain. That is called as chronic pain syndrome. Fibromyalgia is also similar, but it has got a specific feature called a trigger point. One point is the source of pain. If that place is relaxed, the pain will get reduced. And last but not the least, depression and psychosomatic disorders. Depression can often manifest as severe neck pain or severe back pain. So whenever you are examining a patient with back pain, don't rule out all these possibilities. Don't just say everything is lumbar spondylosis or degeneration of this kind. There are so many diseases that can be mimicking the condition. Treatment in conventional medicine. So what is done in allopathy? There are two approaches. One is called as a conservative approach and the other one is the surgical approach. Conservative approach is initially when they go to the doctor, they will be given anti-inflammatory drugs and analgesics. There is a group of drugs called as membrane stabilizers. Have you heard of that? Those who are not in clinical medicine may not have come through that. But these are drugs which are given for epilepsy. I'm sure you have finished your physiology, isn't it? All of you. How does an electrical impulse get transmitted in the nerve? Sorry? Neurotransmitter. I'm saying within the nerve itself, how is it going? From one nerve to the other is neurotransmission. Within the nerve, how is it going? Action potential. Can you say that? Good. There is an action potential. What is an action potential?
Potassium and calcium shift.
And the inside of the nerve and outside of the nerve, there is a difference in the electrical charge. It is usually in a minus voltage that the membrane is at a particular minus voltage. If a powerful current is applied to that, it changes the voltage to positive. And when that charge changes beyond a certain extent, it fires one shot which is called as an action potential. So there are people for whom this base charge is low. The minus is low. So even for a small stimulus, they cross the threshold and it creates an action potential. They are the people who are at high probability of experiencing more pain. So also epilepsy is like higher susceptibility to electric stimulation. A voltage, a small incident is creating a high voltage and action potential is getting formed, and that is epilepsy. So drugs that are given for epilepsy are called membrane stabilizers. There is one category. Those drugs can also be used to reduce pain. Commonly gabapentin and stuff like that. There is a whole group of drugs which are used. Even the anti-epileptic drugs can be used in some neurological pain. Here commonly gabapentin is used. GABA is a neurosuppressor. So GABA makes the nerve potential minus so that a small stimulus will not cause an action potential. So it reduces the ability of the nerve to perceive pain. So what I am trying to tell you is you need to understand the concept, not just the drug. That is very, very important. You may try, if you see 10 prescriptions, you will see, okay, gabapentin is prescribed. So I also gabapentin, but you don't get any benefit from it. If you understand what is gabapentin doing, why is gabapentin used, then you can look for an Ayurvedic medicine which can work like that. You can use the Mahakalyana rhythm sometimes for something that is unrelated. Once you come to the Chikitsa, you will learn about many of our medicines are not for one disease. Diseases which look completely unrelated are treated because it is based on the understanding of how that medicine is working. Ahagalayanagam is given for Ummada, Apasmara, etc. What are the other diseases? It can also be given for Vandhida, Aredasi, Alpaledasi, Devopaha Chetasi, Amayadhasi, Skaladvachi, Smritikame, Alpa Bhavage, Bellim, Mangalyam, Ayusham. And also it's a Mangalyam. So reproductive is equivalent. Aredasi, Alpaledasi, for people who don't have menstruation or spermatogenesis. Even their Mahakalyanagram can be used. See, when we study modern science, today we have the privilege of studying modern science and Ayurveda parallelly. We study both and try to put it together, you will get a beautiful scenario. You understand today from a pharmacological perspective how Mahakalyanagram can be useful in Unnada, Apasmara as well as in Aredasi, Alpaledasi. Because we today know that GLRH is the trigger of the entire reproductive system is starting from the cortex. So the same medicine that is given for a neurological disease or psychiatric disease can also be effective in the reproductive system. This is absolutely scientific. Hats off to those people who thousands of years before they have come out with knowing that same drug can be used for both. Immobilization, okay, the other things are you can generally advise immobilization with a cervical collar. Why? It will prevent the jerking. There is cervical traction that can be given. Not always suggested. In some cases, it can also aggravate the problem. Some cases, it gives temporary relief. And ultimately, neck strengthening exercises. So, exercises to relieve the spasm. Whenever there is pain, the muscle spasm will also come up. Even if it is a neurological pain, secondary to the neurological pain will have muscular pain. So, relieving the muscular pain is the first thing that we achieve, which gives relief to the patient. When a patient comes to us with neck pain and we give him a small massage, he gets some relief. It is not because the nerve is already healed or the disc is fully gone. No. The muscles are getting relaxed, so he will immediately get the relief from pain. If it was only a muscular pain, it will be completely gone. If it is a neurological pain, the pain will be better for some time, it will come back. So these are all things which we need to correlate, which is why this element of anatomy, this element of physiology and understanding the disease from the root cause will give us much more insights and will be the most important thing in our clinical practice. Now, these things are all temporary or conservative measures. Not temporary because many conditions are self-limiting. Very important to know. Many of these diseases will get cured by themselves. Don't do anything also, many of them will get cured. Some of them only have persisted for a long time. Only in those cases where it is not responding, the surgery is supposed to be done. Of course, that is not how it is being recommended. Many of them will immediately ask you to go for surgery. I mean, the system, like every other system, there is wrong usage of science. So sometimes surgery is recommended unnecessarily. But as per classical science, only if conservative management fails is surgical approach recommended. So what is done in the surgical approach? There are many things that can be done. One is called the laminectomy. The lamina, which is the area surrounding the spinal canal, is cut so that the space is increased. So when the space is increased, the pressure is reduced, and so the patient, the compression on the nerve will get reduced, and that's how it will be healing. The other one is called discectomy. The disc which is protruding out is cut away. With the hope that now the nerve that is compressed by the protruded disc will now start getting its nutrition and it will heal. That is the whole idea in both. You understand what is the concept of treatment? Now, what is the limitation of the allopathic treatment approach? The treatment does not address the fundamental problem. What is the fundamental problem? This, what we said, is a fundamental problem. Dehydration. Dehydration and dehydration. The snigdhana of the tissue is lost. For that, there is nothing that is being done there. That is one major drawback. The treatment does not arrest further progress of the disease. The pain will be relieved. One bulk disc is taken off, so that pressure is not there. But there are several other discs. The deranged disc, again, one more pressure, the next dose of nucleus pulposus coming out is possible. Unless it is so severe, they do laminectomy, discectomy, and disc fusion. That is also done in some cases, where the height has become so low that the vertebra can move freely, and it can extremely damage the spinal cord, in which case a disc fusion is done. In this case, that particular vertebra will not cause any problem anymore. But to that extent, the flexibility is gone. That is the other drawback. When multiple discs are involved, surgical correction is not possible. If one or two discs are damaged, you can do that. But suppose you have extensive discs getting damaged, then it does not work as well. That is the golden opportunity for us. From Ayurveda, now you can tell me, I don't have to tell you this. What is the Ayurvedic approach of treatment? Or what are the conditions in Ayurveda, described in Ayurveda which mimic cervical radiculopathy and all that? There are several descriptions in Ayurveda. One is Apamahumam. Amsamolasthiko Vayu, Siddhaha Sankocha Tattaka, Bahu Prasmadidharam, Varier, Apamahumam. So, Amsamola, this is interpreted as adhesive capsulitis also by some. It is interpreted as thoracic outlet syndrome by some. It also mimics some of the features of cervical spondylosis. So, Ayurvedic syndromes are not exactly correlatable to allopathic diagnosis. So don't get worried about it. They were looking at it from a different point of view and they described it differently. Don't think our people did not know anything. They are talking about it. No. For them, the idea was to identify what is the treatment to be done. For that, they had a diagnosis. Today, we have so many diagnoses, but finally, treatment is the same in modern medicine. So that need not be worried about. That is why our Shastras also told us, Vikara Nama Akusalo, the Jifriyal Kalajana. If you don't know the name of the disease, don't get very worried. It was fine in Charaka's time, but today your patient will not value it if you don't know the name of the disease. So for that sake, please study these words. When they come and tell you some fancy word, don't get put off. So you must be able to give him 3 fancy words that he doesn't know. That is part of success in your practice. Otherwise, he will think this guy doesn't know anything. So at least for that sake, you must know some of this terminology and jargon. Okay. This is something for you to do. So Vishwaji, just like Rudrasi is very elaborately described as the radiculopathy occurring in the back to the limbs, Vishwaji is described as Talam Pratyamdilina Kandara Babu Nastataha Babu Jeshtavaharni Vishwaji Nama Sasmula. So the Sira, it is the Kandara that is going from the neck or the spine to the hands, which is responsible for the movement of the hand, that is getting Babu Chestavaharni. So when that is affected, the activity in the hands is getting affected. So that condition is called as Vishwaji. The other one is also Astigata Vata. Astigata Vata is also degenerative skeletal-muscular problem. Degenerative skeletal-muscular problems description also is similar. Astista Sakti Sankhya Asti Shulam Ivram Verakshayam. So when the Vata is situated in the Asti, it produces all these symptoms. But Asti Sandhya, Sakti Sandhi Asti Shulam. So in the lower portion there is more pain. Sakti Sandhi. So even in the joints there is pain. Asti Shulam also, there is pain in the bones. And Tivram Velakshayam, there is severe loss of strength. So these are also happening, but not so much for the cervical region, but more for the lower region. Because more and more weight is coming to the lower vertebra. That's why you will have actually the incidence of lumbar being more than the cervical vertebra. Only because of computers and our not moving at all, cervical radiculopathy is becoming more. Otherwise, basically, human beings are more prone to lumbar spondylosis than to cervical. So now, I am not going into each of this. What did Charaka say? What did Bhagavata say, and all that. Idea is now you understand what is the fundamental pathophysiology. Basic problem is the Snigdhava is gone. And Snigdhava being reduced leads to the body degenerating. It is a sort of a Kevala Vadika condition. It is not a Avarana Vata, it is not some other problem, it is a Kevala Vata condition. Of course, There can be situations where once the disc protrudes, there is a prolapse. Originally, body is not exposed to the nucleus pulposus. Whenever any tissue which is not generally exposed to the immunological system, when that is exposed, the immune system will start attacking. That is causing inflammation. That is why when you have acute cervical spondylosis or any sort of disc prolapse, there is an overlying inflammation that comes there. That is the only issue there. So you might have an inflammation associated with cervical spondylosis, but that is a transient phase. Only for some time it will be there. Chronic cervical spondylosis is a Kevalavada disease. Acute cervical spondylosis can have an element of AMA also. So when there is AMA, what is the Chikitsa Sutra? How do you treat any disease of Vata which has got AMA? First, Nide Niramadam Same. Remove the AMA. Make it Kevalavata. Nide Niramadam Same. Sweda Lendhana Pachanehi. Rukshaischa Alayava Sekadyehi. Kuryad Kevalavata. First, you have to remove the AMA by using Ruksha Prayagaras. Ruksha Ushna. You have to use and remove the AMA. And make the dosha Kevalavata. After the disease has become Kevalavata, give Kevalavata. What is Kevalavata again, sir? Snehanam. Padasya Upakrama Sneha. First thing itself is Sneha. And even for all these diseases, for Astigata Vata, what is the thing, sir? Again, it is Snehanam. Bahya Abhyantagata Snehi, Asti Majjaritam Ye. Vata, when it is sitting in the Asti and Majja, Bahya and Abhyantara Sneha is the treatment of choice. But only thing is, in an acute condition, don't straight away go and use Vata. Don't straight away use Sneha and say that Acharya is wrong. Somewhere else he has told us that if it is AMA is associated, you have to first remove the AMA. So you have to evaluate if there is inflammation. If there is inflammation, remove the AMA by Rosha, Alayama, Seka, etc. and then go for Kevalavada. But the basic treatment for a degenerative disease like cervical spondylosis is Sneha. Understand the principle now? And all the other things also we can use. You can use wearing a collar while traveling. That is not specific for allopathy. It is also something we can use. Very often, the pillow that they are using for lying down is a very important tool. You might have heard that people with cervical spondylosis, what is the advice? Don't use a pillow. Is it right or wrong? It is wrong. You shouldn't use a big pillow, that is all. Actually, for two positions, that the requirement is different. When you are lying flat supine, you have to keep protection for the neck alone. Ideal thing is to make a towel into a cylinder and keep it under the neck because the neck has got a lordosis. If you keep a cylindrical cushion only under the neck, it will support that lordosis and the neck muscles will get relaxed. Then the patient will get relief from the muscular spasm, which will give him relief from pain. So typically, they need to use a cervical pillow. The more important thing is if they are people who are used to lying on that side. If they don't use a pillow, their neck will be hanging like this and they are sleeping. That will cause excess pain. So not using a pillow is not a standard good recommendation for everybody. People who are used to lying on their side advise them to use a pillow which is this big, based on their size. They have very broad shoulders, they may need a large pillow. If they have narrow shoulders, they have to use a slightly smaller pillow so that the neck is erect. It's not going like this. So these are all practical things which you will understand when you understand the anatomy. What is the problem and what is the solution? Clear? And we move on to the next one. Clear about cervical problems? So in classical Ayurveda, what is the treatment approach? Asti Madhyagata Vata is application of oil internally and externally. Amabaho Vidam Nasyam Snehasya Uttara Bhaktika. So again, Abhyantara Sneha, both as Nasya as well as Uttara Bhaktika. After food, you have to give Sneha. Is there any other instance where they are asked to give Sneha after food? Remember fundamentals, Matra Shikya itself, I think it is mentioned. Pran Madhya Uttara Bhakto So Adho Madhya Urdhva Dehajan Vyagin. So when any Sneha is administered before food, it works on the lower part of the body. When it is given after food, it works on the upper part of the body. And when you give it along with food, it works on the Madhya portion of the body. So all these Sutrasthana principles are not to be forgotten in the first year. Lifelong, your entire treatment is going to be based on the Sutrasthana. Everything that is mentioned here applies to everything else. They will not again repeat this when they are in the Chikitsa Sthana, they will never tell you what time of you must give the food. No, you give the medicine. So Uttara Bhakta Sneha is mentioned for Abhahoga. In Vishwaji, what is this? Again, Kevala Vada. So ultimately, if you summarize, whichever be the diagnosis you come to among all the three, the treatment is still the same. Bahya Abhyantara Sneha. You can use Nasya, you can use internal Sneha, you can use external Sneha. Clear? Current concepts, acute state, Siddha Svedam, oil application with warmth and mild massages, but if you suspect more inflammation, use Ruksha Svedam. Labellum can be done. You can also do some Churnamanta Sveda, etc. And then go for Siddha Sveda. Rest, of course, for the initial 1 or 2 days, you can give rest. Don't give rest for extended period of time. That's the mistake many of us make. Making people lie down in bed rest. Earlier, that used to be the treatment of allopathic doctors. They will say 2 months of bed rest for disc prolapse. That is the worst treatment. Should not take rest for more than 48 hours. After that, they have to slowly resume normal activity. Internal medication, anti-inflammatory medication can be given initially. Muscle relaxants can be useful. Drugs for reversing neuronal damage. I think one of the strongest things that is happening with our treatment, especially some of our snehas which are given internally, my observation is that it is able to heal the nerve that is compressed by this protruded disc. So the neuronal recovery is happening. I have treated patients with contracture in the hand. That is, the muscles became so tight that you can't open the hand. With only an internal sneha and some external application, he became normal. He was recommended a third cervical surgery. With only internal medication of sneha and external application of oil, that patient recovered. Sharing my practical insight here. So neuronal damage is getting reversed by our intervention. And in the chronic stage, definitely go for Snigdha Svedam, Nasyam, internal medications with rejuvenative drugs, cervical exercises, postural correction. I told you about how to lie down. So also while working on the computer or working on anything, don't sit like this. More problematic is looking up like this. Continuously looking like this is bad. I've actually practically noticed another thing. Today, many people are using progressive glasses. So even I have a problem. The progressive glass, suppose you want to look far, you will look like this. So if you are looking like this for a long time, you are in hyperextension. Too much of hyperextension will cause spasm of these muscles and that will cause neck pain. So postural correction is a very, very important aspect, and the soft cervical collar while traveling. Are you confident of treating cervical spondylosis now? No sound. Thank you. I'll share our clinical experience also. So we have been, of course, like everybody else, we have been also treating a lot of cervical spondylosis cases. But the thing that happened is my father actually started using our product called Cervilon. He's the one who designed that product as a modification of a traditional Thailand. And this particular thing is fortified version of a traditional Thailand. Along with Kashayams, he was using Ashtavardhan Kashayam and Maharashtradi Kashayam for cervical spondylosis patients. I was a student at that time when I used to sit with him. I used to observe phenomenal success with those patients who used to come for cervical spondylosis. So based on that observation, I started doing some work on that. Which of these medicines is actually giving the result I was trying to identify. So we were also giving external oils, fascia and all that. So we were doing the classical treatment. So I was very curious to find out which is the most important element in this treatment. So I started, when I was practicing, I started stopping certain things. For some people, I wouldn't give this the xylem externally. I wouldn't give the kashayam. I started slowly focusing on the oil alone and found that the oil alone was capable of giving phenomenal relief. Of course, the external application also gives an immediate relief of spasm, but in the chronic problem, it is primarily the internal medicine that is giving relief. That was my observation. That is what gave rise to a product of ours, which is our fastest and highest selling product called Cervila. It was based on this understanding of the disease as well as this clinical observation that helped us to devise this product called Cervila, which we have also done some studies on that. I'm not going into all that. We are just following the same classical Ayurvedic approach. As you understand, it is addressing the most fundamental problem of degeneration with specific drugs. Like Mahadevan sir always used to say, the guna is already clear. Which guna is to be used? Snigdha. Now, which sneha? Can you use all oils? No. What are the medicines in the sneha which are responsible for? They help the product to get targeted. So, receptors are sensitive to specific ligands. So, our medicines, the herbs that are in the medicine, need the action of a particular guna in a particular tissue or in a location. We have different sneha for medhya. We have different sneha for pain. Is it not? We have different snehas for different purposes. Why? The medicines that are given in the sneha are able to target that property onto different tissues of the body. That is why we need different medicines for different conditions. Any sneha will have some effect, but if it is fine-tuned for that tissue, it will have a better effect. For example, kukulu is anti-inflammatory. How many kukulus are there? Boxanari kukulu is there. What is it given for? Urinary problem. But same kukulu, why don't you give Kanjanara kukulu? Same. Kukulu is the main drug. The others are additives. Many of them contain the as well that. What is the difference between Boxanari kukulu has a more effect of kukulu on the urinary tract. Say Kanjanara kukulu has more effect of the kukulu on the Galaganda, Gandamala, etc. etc. So, if you change some herbs in the formulation, the main action is targeted to some tissue. This is the beauty of the Ayurvedic formulations. So that is why we have so many snehas, so many kailas, so many and new products keep on getting made for specific purposes. We can have different combinations. So understanding that from an Ayurvedic perspective as well as from a modern pharmacological perspective is what helps us design modern drugs, modern Ayurvedic drugs. They are not really modern. Traditional products fine-tuned for specific purposes. Most of our snehas you will see are given from head to toe for all diseases it will be given. For example, Nadu, what is the recipe? Sudiga, Bala, Bama, Six, Chene, Supojitamas, Grahakulma, Grahakulma, Gala, Prabhupada, then the Himadam Yoni Lokachaya, the big formula. You study the whole formula, you have 100 indications for the so all our snehas are for multiple diseases. You don't need all those for certain specific conditions. So you can create, if you have the real in-depth knowledge of what is contributing, what effect to each medicine, that is what gives us the insight to create or modify the traditional. The concepts are so beautifully enshrined in the traditional products. I just covered cervical. We'll look into there is also tell me. I have enough life to keep an appeal. Want some more? I don't think the response is uniform. Tired or will stop or what? I have the whole number. Maybe I will just rush through the few other things. Okay, at the same time, I spoke to you about the limitations of the allopathic system. Now, let me also share what I think are the limitations of our treatment approach. In the acute condition, I found that our therapy is not adequate in cases of acute injury with progressive neurological deficits. Suppose there is a severe automobile accident which has led to the rupture of a particular vertebra, leading to a severe spinal injury. Within 12 hours, unless that particular rupture is repaired, that person will lose function forever. So in such a condition, it is not advisable for us to intervene. Because, especially in cervical myelopathy, in any sort of myelopathy, in acute myelopathy, when there is a sudden rupture in the nerve, the function can recover within 12 hours only. So if the surgery can can be effectively done within that time, there is a probability of recovery. So I think we don't have any business to spoil that particular opportunity. So we are not supposed to. This is my personal opinion. Chronic conditions. From my experience, Ayurvedic therapy is very suitable across about 90-95% of people. But there are a few cases where I have not seen response. I'm not saying Ayurveda totally, I'm saying from my experience. Okay. It is not seen to be sufficient in treating spinal canal stenosis. People who have congenitally narrow spine, then they also get myelopathy. I have had patients like that in my entire career. If I remember, there are been 3 patients for whom I have not seen any relief with our treatment. So all those 3 patients are people with congenitally narrow spinal canal. Along with that, they develop myelopathy. And for them, I couldn't really give them much improvement with our treatment. All my experience put together, nothing happened. So I just want to give you that input as well. I think it's more important for me to share failure than success. But everybody doesn't have to fail again. I'm not discouraging you from trying, but I'm just sharing my experience. I'm not the last word in the treatment, but I'm just sharing. I think I'm supposed to share my experience. Right. That's about me. You go to low back pain. Have the energy to listen. So again, like we said for neck pain, this is even more complicated. Low back pain can be caused due to so many different problems. And what causes low back pain? I think this one slide will be the most important slide for you. These 2 slides. And so people are hungry. I think we will rather start. You can't listen and eat together. Hello. Can you wait till we are done? Even without all this, we are enough distracted. I think people are not that hungry. We just had lunch. I am speaking all this while I am not yet hungry. Others can be hungry. Okay. If you want it, otherwise we will stop. Okay, so we'll continue. Are you ready? Or the smell is already coming from samosa. Just bear with me some more time. I think I'll finish in 10 minutes. I have lots of slides, but I'll just rush through and finish in 10 minutes. Can you give me the time without noise? Please. So lumbar strain or strain is the most common cause of low back pain. 70% of people who suffer from back pain are actually having only a lumbar strain or a strain. Lumbar strain or strain means a muscle or a ligament is slightly pulled. That is all it is. And that is 70% of all back problems. Degenerative disc disease or lumbar disc collapse or herniated disc. You have several names for it. All of them represent degenerative disc disease. That is about 10%. Disc were similar. So herniated disc, there is no degeneration. Suddenly there was a compression. They suddenly lifted some weight or something. Otherwise, healthy is fine, but suddenly herniated. That is also happening. This is degenerative. This is not degenerative, but same disc collapse. So all put together, about 14% of patients are having a ruptured disc or a disc-related low back pain. Osteoporosis-related compression fractures account for about 4% of patients. This is global statistics. Cannot be absolutely correct in India. A spinal stenosis is happening in 3% of cases. Sometimes even the ligaments, the posterior longitudinal ligament and not the anterior ligament doesn't cause this problem, but ligamentum flavum hypertrophy can produce some myelopathy and all that. So ligament-related thing can also cause spinal stenosis. It's not only bony stenosis. Anything which reduces the diameter of the spinal canal is called stenosis. So you have condition where the anteroposterior diameter, when you take an MRI, very often they would have measured the anteroposterior diameter of the spinal canal. It has to be 1 centimeter ideally. If it is less than 1 centimeter, it's a red flag that they have some level of stenosis. So then there is spondylolisthesis. I will just be talking about these 1 or 2 conditions. That's it. So spondylolisthesis is a specific condition which is causing persistent and long-standing low back pain. There is another condition called spondylolysis. I told you about that already, where I said the pars interarticularis, or the part of the vertebra which is around the lamina that fractures. That is called as spondylolysis. Then traumatic fracture. Suddenly there is an accident and there is a fracture to the vertebra, that is less than 1%. Congenital diseases are less than 1%. Cancer. Cancer is also something to be suspected. So 0.7%. Inflammatory arthritis causes low back pain in 0.3% of patients, and infections in 0.01, like tuberculosis and all that. This is global statistics. In India, this incidence is likely to be higher. India has a very high number of diagnosed and undiagnosed TB patients. This inflammatory, infection-related lumbar spinal problem could be higher. So I am not going into all this. So I told you about what is strain and strain. When a muscle or a ligament gets stretched and some of the fibers break, that is called as a strain and strain. So that is the most common cause. Just some rest and maybe some cold and hot packs, some labor, some oil application, that will separate this. Maybe a few days of rest, that is what is called. Not a lot of things are given. What are all the muscles involved in the back? So which muscle will cause what sort of problem and all that. So let's maybe you can go through all of that. But you understand, 70% of problems related to low back pain are muscle-related problems. So when somebody gets a low back pain, don't immediately say it is lumbar spondylosis. This is why we get a bad name. You will say, I have already successfully treated lumbar spondylosis, and when somebody examines, there is no spondylosis. They will say, what, you are cheating. No. So all back pain is not. So 70% of low back pain is self-correcting. Within 2 to 1 week or so, it will automatically get corrected. And mostly they will not come to us, unless you are the only doctor available. Everybody knows they will go to an allopathic hospital and take a painkiller, or they will go to a medical shop and take a painkiller. Only when all that doesn't work, they will go to an allopathic doctor. And only when that doesn't work, they will come to us. So we will invariably see the chronic patients. That is where our expertise has gotten. So also the ligaments. There are several ligaments associated with this thing. I was telling you about the posterior longitudinal ligament, the interspinous ligament, the facet capsular ligament. There is capsule, there is a ligament. Supraspinatus ligament, ligamental flavor. So there are several ligaments which are holding these vertebrae together. Any of this ligament is getting slightly stretched or pulled, there will be pain, local pain, which can mimic lumbar spondylosis. So don't immediately jump to that conclusion. One of the cardinal things you will look at is the disc dehydrated. Is it prolapsed? Is the vertebral integrity gone? If your MRI is fine and the patient still has low back pain, it could be commonly, if it's acute origin, it can be lumbar strain or strain. But first, don't take an MRI also. Just give it a week or 2 weeks for it to settle. Only if all that doesn't happen, ask for an MRI. Now, that is another fancy. Everybody coming to us, we are prescribing an MRI. That is also not required. And when they have pain in the legs, don't prescribe for an MRI at the thigh. Okay. Pain, radiculopathy will come there, but the problem is here. Now you know enough anatomy to say, if he has got pain that is coming along the side, don't tell him to take an MRI of the thigh. No. Pain, that is not required. Other specific disorders. I think I spoke to you about lumbar degenerative disc. Up to 75% of the lumbar spine occurs at L5S1 and L4L5. Most common site of lumbar disc degeneration is L4, L5 and L5, S1. So as I told you, there are several factors that are responsible for that. I spoke to you about spinal stenosis already. Now spondylolysis. I told you there is an anatomical defect in the bones interarticularis within the lamina. It can be happening on one side or on both sides. It can be congenital or it can be induced. Usually without clinical symptoms with incidental finding on radiograph. These people can have that problem and with no symptoms they will be there for a long time. Suddenly when they take something heavy, they will develop severe pain. And when you take an X-ray or an MRI, that is when you will find there is a problem. What is actually happening? See here. So this bone part which is here is actually broken. The connection between this part and this is what here. There is a crack. You see here. So this is called spondylolysis. To detect it is not very easy for us, but with constant practice, if you go on looking at it, I am also going to show you an X-ray or an MRI, with which with expertise you can detect. So this is there is a defect here. This is called, I mean, you must be able to see a horse ear shape and all that, and then that is reserved. That is how spondylolysis is detected. I think today in India we are all very lucky. We can suggest an MRI, the radiologist will do the diagnosis and give us the diagnosis. But only understand what is at least that we should not skip the spondylolysis. So spondylolysis is a very, there this fracture, this is actually a fracture of this vertebra and it will not heal. Even if you treat it, when somebody asks you, can you cure spondylolysis? You must ask them what you mean by cure. If he wants his back pain to go, it will go. And if you want this broken vertebra to fuse, it will not fuse. It is a non-healing fracture. Only with surgery it will heal. It will not heal by itself. So don't tell them you will heal the fracture. And it is not necessary to heal. I am a person who has got spondylolysis. And there is nothing that I don't do. I climb mountains, I lift weights, I do everything. Okay, so you can be practically normal with spondylolysis. Only thing you need to do is address the acute issue and then strengthen the core muscles. I think most people with lumbar problem, the ultimate solution is strengthening of the core muscles and good posture. If these two things are taken care, they can survive. If there is radiculopathy, that is when we will need the treatment that will get help. The next one is spondylolisthesis. The progression of spondylolysis with separation. There are two types. Can be assigned grades from grade 1 to grade 4. The most common level even here is L5S1 is 70% and L4 L5 is 25%. So this spondylolisthesis means slippage of a disc. This is where actually it is slipping. Spondylolisthesis is the disease where one vertebra slides over the other. If you look at the alignment of all the vertebrae, most of them are horizontal. When it comes to L4, L5, it starts becoming like this. It is so much, there is so much of a lordosis that the joint is almost like this. So it is easy to slip. If it is like this, it is difficult to slip. When it is like this, it is easy for it to slip. This is what is happening in spondylolisthesis. I will show you a picture also of how spondylolisthesis happens. Just see here. This vertebra has actually slipped here. So what happens is that here the nerve, so if you see that this the nerve that is coming out through this intervertebral foramen will actually get compressed because the bone is shifted here. Depending on the level of displacement, now this is like almost grade 2. So if it is only slight, it is called grade 1, grade 2, up to grade 4 is there. Beyond grade 2, it is very difficult to correct without surgery. Up to grade 2, you can treat spondylolisthesis without surgery. But most importantly, they need to have continuous exercises and core strengthening. Acute phase, they will not be able to do exercise. Never recommend extension for them. Extension will worsen this. If you see this, they are extending the spine is bending further, it will slip further. So generally, people say people with back pain, they are given Bhujangasana. Don't give Bhujangasana for this patient. Okay, back to, okay, asanas. Bend forward, bend backward. No, not for this thing. Very important to know who is to be given full range of motion on the spine, and this guy needs only flexion. That should not, this way he has to lie down, and Pavana Muktasana is one of the most safest things to reach people. It will really relax the muscles as well as help realign this thing to some extent. But most important exercise for lumbar spondylodepression after the pain is gone is plank. You know the plank exercise? All of you? Plank means you have to be like a bench like this. Keep your hands on the floor and then lie down like this. hold that position for a few seconds, increase the duration. Ask the patient, most patients will not be able to do more than 10 seconds initially. The hands are so weak that you can't hold your weight for 10 seconds. And if you can try, you will find your hands are shivering. But with practice, you can make it up to 2 minutes. 2 to 3 times you can do that. Then there are advanced planks also. This is the basic plank. Then you have a high plank. Keep your hands on the floor and lay down like a plank. So these sort of exercises strengthen the muscles which are supporting the spine. And that is what will help you prevent back pain in the long term. So we need to know the biomechanics also. So here is spondylolisthesis, you see, a full forward slip. So I told you here, at that level, the intervertebral disc is like this. Now it has started tilting. Because of this tilt, it can easily slip. And when this happens, they will say here is a spondylolysis. Because of this spondylolysis, this vertebra has slipped. Though the ligament is holding this vertebra has slipped. Then there is spondylitis, ankylosing spondylitis is there. It is an inflammatory condition of the sacroiliac joint. Go on and on. I think we will stop for the time being. Okay, the last one is non-organic causes of back pain. As I told you, there are several conditions which can cause back pain, but there can be back pain without any of these conditions. Superficial tenderness over the lumbar spine. So there are some people they go for an MRI. MRI is done, no problem. Okay, but patient will say I have terrible pain. You do a physical examination, they will say pain here, there, here, there. Even when you touch, they will say, oh, it is terribly pain. Okay, or non-anatomical tenderness in a place where there cannot be pain, they will feel pain. Exacerbation of pain by applying a few pounds of pressure with the hands on the top of the head. Suppose you are just pressing the head, they will say, oh, terrible pain is there. That's all psychological. Because if you press like this, the spine is not going to get compressed. But they will think it is getting compressed and they will get pain. All these are actually psychological problems which are manifesting as back pain. Be very much aware of this. Don't tell them you have got a psychological problem, but come to them. Probe deeper. Ask more about what is happening in your family. Are you happy? Are you sad? Are you worried? Are you crying? How is your relationship? Things like that. Counsel them if you can, or send them slowly. Give them psychological support, and also some medicines which are addressing anxiety and depression. Most commonly, depression causes severe back pain and retractable back pain, which does not respond to any treatment. Even with painkiller, they will say, I am taking everything, but pain is not going because it is in the brain. Actually, pain is in the brain. Do you know that? Pain is not where it is actually happening. Pain is just one part of the brain giving an electrical signal. So, if you are emotionally in a bad state, you will automatically get pain. The person who has got severe pain, suppose he is in the midst of his best friends, he will have no pain because the brain is busy with good hormones. There is good neurotransmitters here, and there is no pain. The neurotransmitter level becomes negative, all the pain will aggravate. So pain is always a psychological phenomenon. And this is more so. When there is no anatomical correlation, no, the deep tendon reflexes are fine. Your physical examination shows we are talking about pain in different places at different times. The ability to sit straight from a supine position, you are asking them to lie down and you are asking them to get up, they will get up. But intolerance of straight leg raise, you are asking them to raise the leg, they can't raise the leg. That is again an indication that there is a problem. Actually, both are the same. If they can do one, they can do the other. In fact, sitting up from supine position is more difficult. If they are able to do that, but straight leg raise is causing a problem, you can detect it is a psychological problem. And these indicate psychogenic pain and are due to depression or chronic pain syndrome. So please be aware of this. A good number of patients are actually suffering from this problem. And if you address them psychologically, their pain will be gone, not otherwise. Red flags, what should you be worried about when you're treating spinal problems? History of cancer, unexplained weight loss, intravenous drug use, people who have been using of corticosteroids. If people are for some other disease, they have been using corticosteroids, you must suspect osteoporosis or avascular necrosis. Older age, major trauma, osteoporosis, fever, back pain at rest or at night, bowel or bladder dysfunction. These are all red flags. When you are taking this back or neck pain and you are seeing these problems, immediately red lights should burn in your head. That could be something troublesome. And Ayurvedic approach, if it is muscular strain, just mild oil massage with rest or one or 2 days. In that massage, don't use all the pressure. Some people think massage is effective only if they are pressing the life out of somebody. Don't do that. Just mild, this thing is enough. In degenerative conditions, treatment of the underlying degeneration. Of course, Kevalavada. He said the basic spinal problem is a Kevalavada disease, so that is the treatment. Non-organic causes, counseling and appropriate medication. If they have got severe clinical level depression, they need to be treated for depression or anxiety or whatever is the cause. In inflammatory conditions like autoimmune sacroiliitis, anti-inflammatory and immunomodulatory treatment. So the crux of the matter is treatment is not the problem. The problem is diagnosis. So I would again quote one of my favorite quotations when it comes to the spine. The challenge of the primary care specialist is to be able to recognize the more serious disorders that require early referral. Additionally, it is important to have the confidence to institute specific treatment for non-urgent conditions in order to avoid unnecessary referral of patients with generally self-limiting conditions. So, to know what is complicated, what is treatable, what does not need treatment, I think is the real challenge. And I hope today you are much more equipped than when you came to the lecture to at least have a view of all the different things that could be you should think about when you are thinking about a spinal problem. Thank you so much for your patient listening.
Thank you, sir. Thank you so much, sir, for fueling our patient through your session. I am confident that everyone here will gain something from your session. Now, I request Dr. Evangeline sir, Principal Emmanuel Arthur Ayurveda Medical College and Hospital, to honor sir with a shawl and a memento. Once again, thank you, sir, for being a speaker at today's event.
Now, we will have a video play as an introduction to how our international conference and our ISQG in search of new modernize in Ayurveda, integrating artificial intelligence in Ayurveda.
college and hospital to Nadu. He is a renowned oracle in the field of Ayurveda, spreading his vast clinical experience on the topic, a perspective on disruptive technologies for drugs and device development in Ayurveda. As a seventh session, we have invited an internationally flourished entrepreneur in the field of Ayurveda. We are happy to raise the occasion by Dr. Veer MD, MPhil, Managing Director, Baptist Ayurveda, and Dr. Shyam Ayurveda, UAE. Dr. Veer will be sharing the well-awaited session on exploring the integration of AI and machine learning in clinical Ayurveda practice. Our eighth session is blessed by experienced Ayurvedic teaching faculty, Dr. Prasanna Kulkarni, MD, MS Genetics, Professor and Lecturer, Department of Swasthapradhan, Srikant Parameshwar Swami, Ayurveda Medical College and Hospital, Research Center, Bangalore. He will be sharing the topic, the role of artificial intelligence in advancing Ayurvedic education, clinical practice, and research. Ninth session will be carried out by Dr. Sahib Ramfikula, Research Officer, CCRAS, National Institute of Medical Heritage, Hyderabad. He will be sharing the topic, benchmark for the pragmatic usage of artificial intelligence in Ayurveda domain. As a 10th session of the scientific conclave, we are thrilled to reserve an internationally recognized Ayurvedic practitioner, Vaidya Ram Prasad, BMS, CACH from Australia. He will be spreading light on the topic natural and artificial intelligence in holistic healing. From insightful keynote function to interactive panel discussion, the conference will offer a wealth of knowledge and inspiration, exploring ethics, a thoughtful insight to artificial intelligence, the human intelligence. Welcome you, all respected IIT scholars, to NAVA IIT 2024.
Now, I request delegates from the college to stage for taking photos.
என்ன சொல்லுங்க? 2 வீடியோ ஓடணுமா?